Hello everyone and welcome to today's Digital Health webinar. I'm Tammy Lovell, editor at Digital Health, and today we're going to be speaking about digital tools that can help with prevention, which is one of the three big shifts in the 10-year health plan. I'm joined today by three panellists. If you have any questions for the panellists, if you can just put them in the chat box. We're not able to see them if they go into the Q&A box, so just use the chat and I'll try and have a look at those and read out any during the discussion. So I'll go over to the panellists to ask them to introduce themselves. So I'll start with you, Rachel.
Thank you, Tammy. Hello, everyone. Thank you for joining us on a Friday. It's great to see people flowing in. So my name's Rachel. I look after digital prevention services at NHS England. So what that means is I look after digital services that help with things like vaccinations, screening, new digital health checks. We're building some home testing tools and various other components, which are all building up to try and give a sort of joined up experience through the NHS app. So hopefully this can be an interesting discussion. Do keep your questions flowing.
Thank you, Rachel. And I'll go over to you, Andy.
Hello, everyone. Likewise, really happy to be here. So I'm Andy Poole. I am Head of Data Science and AI for Dorset, working across providers, GP and ICB and social care. I also am the Head of Data Engineering for DICE, the Dorset Intelligence and Insight Service, as well as being a CIO advisory panel member. I'm really excited to be here and talk about prevention and neighbours and how we really start to deliver some impact in this area and how digital is going to be one of the key enablers of that. Thank you.
Thanks, Andy. And then finally over to Gary.
Hi everyone, I'm Gary McAllister. I'm the Chief Technology Officer at Dell. I was previously in the NHS for over 26 years with roles at acute trusts and then at ICB level, then regional level, and then I was in the national team for just over a year, nearly 18 months working on strategy and planning. So really looking forward to talking with colleagues and hearing the questions when it comes to prevention and hopefully improving the health of our nation, which is the ultimate goal.
Thanks, Gary. So we'll start the discussion off with the kind of basic, like what are we really talking about when we talk about prevention? What does that include? And what does it mean when it comes to digital? So he'd like to start with that one. Maybe you, Rachel?
Yeah, I mean, I won't get into all of the technical definitions, what's primary prevention, secondary or early intervention, because I think it's more important actually that we take a holistic view across those different elements, although there are obviously slightly different things we need to do at different parts. But I guess the big question, well, actually, let's take a step back. What we often get asked is why does prevention matter and sort of why now? And I'm always reminded that prevention has always been at the core of the NHS, and other people have heard me say this before, but when you go back and look at the 1948 documents of setting up the NHS, it talks about how we'd be doing such a great disservice to our doctors if they are only constrained to treating people who are unwell rather than helping them stay fit and healthy. And I guess that hasn't always been a consistent priority throughout the years. But what we're seeing now in terms of the government's commitment to the three big shifts, so everyone probably knows these off the tip of their tongue, but that commitment to moving from analog to digital, from hospital to home and the community, and crucially from sickness to prevention, has really put the spotlight back on what we're doing, and with good reason. So some of the real important things we need to think about is, I saw a stat the other day, which was actually a new one to me, which is 1 in 5 deaths in 2023 were considered preventable in England. But more broadly, preventing ill health is also not just about that really important thing that matters to me and matters to you and your families, which is keeping people healthy. We want to keep everyone we know and love well, but it's also really important for the long-term future of the NHS and to the economy. And so others will have heard me talk about the triple dividend. So it's about healthier people, that healthier economy, and the healthier finances. And that's really brought into Startlight when you look at, how long-term sickness pushes people out of the workforce. I think we've got a near record 2.8 million out of the workforce due to long-term sickness, and a growing number of people who are limited within the workforce because they have a health condition, and that's been a big million-plus increase over the last decade. And we see the cost of cardiovascular disease mounting up to 25 billion, cancer mounting up to 13 billion. So I think on the one hand, we've got this burning commitment to try and keep people healthy because we all care about that, but we've been increasingly able to make the case to the Treasury and others who unlock a lot of what we need, that it goes beyond that, and it really matters to the health of our economy and the future of the NHS. So I think that's the sort of strategic context in which we're operating at the moment, but I'm sure the others will have more to add, and I've hopefully given you a bit of time to think.
Thanks, Rachel. I mean, the interesting thing around this is the economic impact. And one of the things that we learn, I also support the Digital Leadership Academy with specific parts of their program, and the quality adjusted life years and the economic impact of poor health is significant. And if you can create data and information platforms which help people manage their lifestyle and better, and we actually, I was reading about vaccinations this morning actually, and making sure that our vaccination screening rates are up to scratch, so to speak. There was a period for one reason or another where London had the same early year vaccination rate as a third world country. So there's been a lot of work done over the last 5 years or so to ensure that the public health issues have been resolved. But from a data platform perspective, Andrew is very well placed to talk about kind of the opportunity when it comes to leveraging data for the purposes of improving health outcomes and prevention. So I will talk about the London data service at some point, but Andrew, do you want to come in with your perspective?
Yeah, thanks, Gary. Yeah, I kind of want to echo what Rachel and Gary said, in that what has happened, obviously, with all the background context on financial pressures and aging population, means that we've kind of lent towards when there is a need, fulfilling that through primarily acute services, and that's led to a series of kind of waves, and that's the sensible short-term answer to when there's pressure. But in the long-term answer, it's about prevention, and actually how do we reduce that demand and create longer, healthy life expectancy, as everyone's kind of said. So in terms of kind of digital, then I see 2 or 3 ways that predominantly digital will enable prevention, and I think the key for me is it will be an enabler. It won't necessarily be the outright driver in most circumstances. One is the kind of the automation and speed aspects. So if you think about AVT, that's obviously in the news this morning, and you think about kind of time for referral, for triage, and the results of blood tests, and that kind of process, that will get quicker, that will speed up, and in terms of efficiencies, deliver slightly faster results. And then the other kind of areas are around identification. So if you think about the opportunities with traditional methods, was research, data science, and as we move into an AI world where prediction and diagnosis will be part of standard triage solutions and one-on-one solutions in the coming years, and that will mean that conditions are known well in advance. We can speed up the kind of process. One of the other areas that we'll get to, I'm sure later, will be innovation and the opportunities around lots of things that are kind of further down the line. I'll allow Gary to come in. I'm sure you've got some examples as well you want to talk about.
Yeah, one of the interesting, and it is on our list of things to talk about further on in the webinar, is the impact of genomics and the genomics medicine record, which the genomics team are working on in the centre, and how we get to kind of a critical mass of sequencing of individuals. Because I think some of the challenges that we have as an industry is that a lot of time is spent on, I would say, even from the digital plan, more traditional methods of managing chronic condition or the onset of chronic condition or even the prevention of chronic condition, whereas the future has to be about your predisposition and your genetic kind of material that makes you susceptible to certain challenges in life, which if you had prior knowledge to those challenges, you may decide to live your life slightly differently. So I think the coming together of the current plan, which we'll talk about, and Rachel will go into a bit more detail, and then the kind of future plan, which has to be like pure prevention rather than early diagnosis, which we tend to, when we talk about prevention, we tend to kind of get the two mixed up. Prevention is about stopping people getting unwell, whereas early diagnosis, which can be confused with prevention, is detecting the onset of a problem as early as possible to treat it and manage it downstream. So, it's a really great panel to talk about these kind of things, because there's the kind of coming of the new age, and then the current kind of plan and strategy of managing early diagnosis, which is slightly different. So maybe we'll move on in the conversation, but kind of just add in another kind of angle to the discussion.
You mentioned a few things there, AVT, AI, genomics. So what are actually some of the digital tools we've got at the moment which are really making an impact on prevention?
Shall I come in first? I mean, there's a nice sort of three horizons that are already starting to fall out of some of this conversation. So I think there's lots of different aspects to it. At the moment, there's a lot of focus on how do we reach people and enable them to understand what their risks are and improve their access to preventative action, like Gary, you mentioned vaccinations. How do we get more people vaccinated and more people vaccinated consistently? I think some of the digital tools we have in our pocket at the moment that are being exploited right now are things like the NHS app. Like, we shouldn't underestimate how much that has gone from strength to strength since the pandemic. So obviously the pandemic meant that many people had the app in their pocket, but what has changed in recent years is the number of people who are really actively engaging and using the app as it's brought more and more services on. So three in four people in the country have the NHS app, but I think they have I checked the other day, 3.6 million active users every month, and that goes up particularly around winter. So that's a phenomenal reach. I think most commercial organisations would kill for the reach that the NHS app has. So we shouldn't underestimate that or underplay it as people who are working in the NHS in our ability to reach more and more people directly. And then when we partner that sort of national capability to reach out and tell people they're eligible for things, make booking easier, we also need to partner it with, well, then what does that actually mean on the ground? So if we use vaccinations and keep with that as an example, there's obviously increasing work to make sure that vaccinations are as close as possible to people in ways that they can access it. So whether that's increasing the number of vaccinations that are offered through community pharmacy, which is ongoing, or improving the number of vaccinations that are offered at the same time people are in their maternity wards having their screening for pregnant women, all of that's happening to improve access. And I think they're really important kind of fundamentals, and attached, because Gary, you started with data and information platforms, it's also attached with just empowering professionals in the NHS to know whether someone's had a vaccination, so they can have a much more sensible conversation rather than having that sort of information tied up and locked away in sort of different parts of the system. That's having quite an impressive impact in the areas where we've gone heavily. And I might pause on what we have now so others can come in, but then we can talk about then what are the more exciting, maybe not more exciting, but the shiny things that are coming down in the second and third horizons, which are certainly work that's ongoing at the moment, but there'll be a lot to do to get that to national scale.
I guess
you go ahead, Andy. You go first.
So yeah, it's really interesting to hear. So I think we're already kind of identifying two kind of areas here. So one's how do we work with the existing system, and how do we enable that to be the best it possibly can be by identifying, sharing data. And there's a kind of second element here, isn't there? What's the long-term difference? I'm picturing a vision of the future where everyone from birth will have a genomic profile that will know their risk, that they can manage those through their lifetime. And this, I guess, I'm really interested in, can we get into how do we prioritize both of those? Because right now we're living in a reality we're going to have to deliver what we've got, but actually that's a vision for 10 years time that I'm sure we'll get there. But one of the things we're talking about at the moment, nationally and locally, is a payback period. In terms of, if you do a cardiovascular intervention, it's a 10-20 year return on investment for the population. But actually, if you do other things, can you make more of an impact, particularly in this current economic climate? But I guess it's probably from a selfish perspective, from a local, is that we're looking for those quick wins and those how do we use the data and information across the system to identify those people that really need those interventions. And then the actual interventions that happen are often not even digital. It's just that we've identified a very refined cohort that actually has this very specific need, and there's various methods. Rich stratification is one of the older approaches, and machine learning and AI that we'll start to use in MTTs and triage in the future as well. I'll give an opportunity for everyone else to kind of have a say, but I guess I'm interested in that balance between how do we set the groundwork for the future versus actually starting to deliver now.
I think that's a really interesting challenge. I mean, the problem when you talk about data, there's like the obvious things, isn't there? There's like understanding, how many of your population have been vaccinated, and then creating, local neighborhood programs to improve the vaccination rate, and then obviously like the social demographic issues that we have with regard to deprivation and managing deprived communities and ensuring that their lifestyle choices are improved, eat better, better housing, and all that sort of thing, which improves health outcomes in themselves. But they are, you would say, like the I would say the simple kind of data type challenges that we have when it comes to prevention. It's knowing that there's a problem and creating infrastructure estates, economic programs to improve the health of and the culture of our communities. I mean, there's some still, we talk about deprivation. We have shocking statistics in this country around, if you live in Southwest London in Richmond, your life expectancy is 10 years more than a person that lives in Blackpool. I mean, that's a still a shocking statistic. We know that's an issue, but the kind of the cultural challenges that we have and the economic challenges of employment and all those things that go into making, you would say, significant change is, as you say, is like a 10-year problem. The big stuff, the exciting stuff that we've got coming on the horizon around the genomics medicine record and the single patient record and the health data research program, which will create a repository to support population health management and other kind of academic health challenges. I think it's a real opportunity for the NHS to lead the way and then provide tools in the NHS app to encourage our citizens to live better, eat better. There's a core 20+5 framework that's been around for quite some time, but it focuses on the very kind of the long-term challenges that we have in our communities around mental health, smoking, alcohol, drug abuse, and it goes more broadly, respiratory problems and things like that. So there's those things that public health programs and prevention programs can make a real difference. I think the challenge is getting the data into a shape where you can actually do the population health analysis and statistical interventions, if you like, but then it's translating that, and as you've said, and getting over the financial challenges of, okay, we've recognized there's a problem, how do we get the funding and the resources now to do something about it? And that's again a big prevention issue for our communities and for the NHS as a whole, certainly in the current climate. So I've added a bit more, haven't I, and certainly in the technology space there around the national single patient record, the HDRS program, which is a new chief exec announced this week, and then the community and local data challenges through previous like ICB, CCG type platforms that were built over the years. So really interested, I suppose, Andrew and Rachel, around your kind of where the denominators will sit moving forwards with some of these challenges, because obviously, there's a national view and a more local view.
Yeah, really. I mean, one of the interesting things that people often ask me is, what is the one single thing we should do to really push the prevention agenda? And I think Andy and Gary, you've just both really articulated why we can't just do one single thing that will help us. Hopefully you can still see me, everyone. It just paused. One single thing that we can do to really shape it, because we need to approach everything. Bear with me, everyone. I'm getting some interference on my side. Is anyone else? Am I there?
You're okay for us.
Fine,
You're okay.
Rachel.
Yeah, go for it.
Fabulous, fine. I will crack on and hope for the best. Just shout if not. So with that in mind, like with all these layers, what do we need to do that, Andy, your question's really interesting around what are we doing now that enables us to keep making the immediate progress that's needed, because we're in, let's make no bones about it, we're in a critical situation and needs to be immediate action that has some immediate impacts and some long-term ones. And then we also, particularly in digital, need to be thinking about what foundations are we laying and how are we going to make progress so that the innovations aren't these far off things, that we can keep bringing them closer and closer. And I think there's quite a few ways of thinking about it. But if we take a step back, quite a lot of public services have been, and particularly in the NHS, transactional in nature. So we say, come and get your vaccination, or please come and be screened, or have your heart health checked, etc. Whereas when we really think about prevention and what we need to do there, and harnessing some of the future things, it's actually there's no really one single user journey. It's much more in the prevention and an ongoing relationship between the citizen and the NHS. And that relationship, which is really important right now and for the future, is being increasingly mediated by digital and being increasingly data driven. So what that means is we're having to sort of think about the way we build our services in a different way underneath it. So let me bring to life what I mean. Otherwise, the saying is, we particularly in prevention talk a lot about the service loop, and by that we mean that essentially there's some core common components. So the first bit is obvious, it's more data. It's a pretty safe bet to say that there'll be advances in, all of the sort of things like wearable technology, diagnostics, AI, and over time we'll get more and more data. But right now there's some just basic data that we need to get flowing into in a consistent way that can be seen across the system and for citizens. There's then a part which means, how do we help people interpret what it means? So that's both the public again and clinicians, so the ability to understand that data really easily, then understand the sort of do next part, which again sounds easy, but actually it's not that obvious sometimes. If you get told your heart health age and your cardiovascular risk score, what do you really do next? What's most important for you and your context? And it might be different for someone who's a smoker or someone who's got certain weights, etc. And then there's the do the thing, and then that should feed back through into more data that can help us. But what's quite different about prevention than other areas is that we're less worried about what people have done, the record of their clinical interaction, whether they've had a hip replacement, etc. But we're much more worried about what they haven't done. So creating a sort of health record of what hasn't happened, and where there is a gap helps us then build up a prevention picture which we can target. And over time, as we have more and more information about people's predisposition to certain risk factors, so whether that's genetic, like we talked about, or something that they're a smoker, we can add that in. So I think that's really important. The second really important thing that we can build right now, and we can gradually populate and build it out as the genomics data lands, and we can increasingly interrogate it more as we use AI tools. But the second thing is, that I really wanted to say, was we really got to make sure, and I'm stealing a colleague who said this to me just before Christmas, more data is great. Obviously, we want more data in the land of prevention. It doesn't take a futurist to predict that more and more data about our health will help us, but it absolutely can't be a fire hose of information. And we need to be really clear that the important role, particularly for people who are creating the digital interfaces, is about designing the clever way people can interact with that data. And that will be different for different people's needs. But essentially, we need to exercise discretion and we need to be really clear about intent. Otherwise, there's a risk we sort of say, let's get all the data and put it somewhere and give it to people and hope that has an outcome. And that's probably quite unlikely in the prevention space, because that brings me on to just the third thing, and then I'll pause for the others, is the bit we haven't touched on yet is quite a lot in the prevention space is about behavior change. And that's a simple behavior change of getting your vaccine for the seasonal flu, or something which is a lot harder when we're thinking about smoking cessation or weight loss, or wider dependency on alcohol, etc. So there's something that we need to do in terms of building digital tools which establish a relationship. So you might have noticed the 10-year plan talked about an AI health coach, which is something that's been tested in terms of does that give a way that we can have ongoing engagement with someone, because ultimately prevention is about the future. So there needs to be action now, but it needs to be sustained. And it also needs to help people think about both their immediate risk, am I going to get flu this winter, but also the long-term risk. So something they're doing now that might materialize and impact them in the future. And that long-term risk is much, much fuzzier. And so we can start building and designing the digital tools that help essentially with that whole service flow, help with the behavior change, help create these different sort of time horizons that people are thinking about in terms of their own health and the health of their families. And then as we get more and more technology, we can sort of help with each of those interactions, but it helps us break it down in terms of what we're building. So that's at least how I am, and I'd love people's views, so please pop things in the chat. Love people's views on where we've got gaps in our thinking, because it's very much evolving and we're testing and learning as we go with some of these tools.
Yeah, I mean, it's a really interesting kind of paradigm that we're shifting towards. I mean, we're moving away from, as I said, like it's very reactive health system that we've created to a very proactive health system, which is a significant change. I mean, there's a lot of information on the public health website, England website, where, we know the cost of long-term challenges of, people who unfortunately get breast cancer or have a stroke or end up with diabetes. But you're talking, around 75,000-80,000 pounds per person over a 25-year period. It's a significant portion of investment needed, and if you've got high populations with these challenges, then it becomes unsustainable, especially in the context globally of the estimated 3 million doctor shortage by 2030, which we just won't have the workforce to look after our population if we're not careful. I mean, coming back to the kind of tech thing, I was lucky enough to get myself a Whoop for Christmas, which monitors my sleep and my heart rate and all these other things, and I do a bit of running here and there and try and keep myself reasonably healthy. But I'd be interested to hear kind of Andrew and yourself, Rachel, and like what you think longer term the kind of prescribing landscape looks like for these kind of devices, and like how they fit with the prevention strategy. Because obviously, in China now, these walk-in robotic clinics where you can go in, be completely kind of screened on a one-stop, no human intervention, and they'll completely give you the kind of once over using a whole bunch of sensors in a kind of walk-in box that sits just on either on the high street or on the roadside. So we will move more towards that kind of service. But I suppose they're coming back to the culture is like, how do we get the technology in people's hands, especially when we have economic like diversity and affordability diversity. So, and from a data perspective, Andy, you'll just coming back to this fire hose point, there will be a lot of it, and with the right risk models and the right AI, you could do some quite powerful things, I think.
Yeah, Gary, I think it's really interesting what you're saying, and I was reflecting a little bit, Rachel, on what you said. So I kind of see there's two areas that are going to be looked at. So one is an individual's personal management of the health, and there are tools out there that we're creating, like the NHS app, that will be massive enablers, and the health coach. And then there is enabling the existing system, which I think the focus seems to be shifting towards a neighbourhood management and PCNs and that kind of area as the lead contact point for individuals. And how do we enable them? So I guess I'm almost seeing a really quite nice split of, actually there is a kind of almost a national effort of we're enabling the individual to manage these tools and engage with these areas, and actually locally we're developing systems. So for example, we're currently piloting something called the Targeted Prevention Hub, which is an MDT rising risk profile management that brings together social care, voluntary sector, GP, secondary care data all into one area, so that risks can be highlighted. It links to the kind of through to like a shared care record kind of view, and that way you can very quickly analyze and assess whether there is a modifiable factor that can have an intervention. Kind of we're trying to streamline that process through to, can you get to a clinical assessment of, is there anything we can do here? And then X, Y, and Z are the possible interventions. And I think that's where maybe even research comes in. The research cycle has been quite slow with pharmaceutical background, but actually as things get more medical devices, will it accelerate? Will we see 2 or 3 interventions maybe locally on our platform? We'll be able to evaluate who was identified, what intervention was take place, and then can we scale that across a cluster or a region? And I think that's the mechanism. I'm thinking about a delivery mechanism for enabling that change for the existing system. And I guess it doesn't matter whether it's a pharmaceutical intervention, whether it is a prescriber of a wearables to individual, or they could do it themselves. If that data can feed into that process, then we've not only got individual management, but we've got the system looking after the individual as well. I think that's the way I really want us to get to. I guess I'm particularly interested, Rachel, I don't know whether that fits in with your view from National.
Yeah, I mean, the big thing that, actually taking a step back, there's often a conversation that comes up sometimes, which are things like the NHS app, which I talked about at the start, and local initiatives like you just talked about, Andy, are they in stark contrast, or the push to do more localized intervention in stark contrast to some of these national products and services? And my view is that absolutely not, and they should be working in parallel. The NHS app is a fantastic surface, which I and others locally use to surface interventions. But I think we need to get out this mindset of integrating with local services about being about signposting. It's absolutely not. I think the aim has to not only be, if someone has access to something nationally, to refer to local services, but actually help them successfully complete that and share information back round. So it's more joined up beyond the local area. But it's absolutely pivotal that whatever happens with these national products and services is that they really support, help propel forward local initiatives, because a lot of prevention is about, like we talked, behavior change, but relationships and what happens to you and what's around you and what you and your community needs. So I think national healthcare apps like the NHS app need to allow for local prevention services to integrate really deeply. So notifying users of changes to bookings, asking for feedback, I think is quite important, and encouraging people to complete referrals such that the local services can really flourish and use them as a tool as needed to move things through. And while you were talking, actually, I was thinking, because it's quite interesting around all of these different initiatives. And the other thing that you often hear in the NHS, which I'm sure we're slightly bored about, which is, oh, there's a great initiative there. If only we could get it to scale, and scale is probably the wrong word because it implies that initiative works for everywhere in the country, but grow naturally across the country and be sort of tweaked for the population in the different areas. And I think one of the things that we need to do more of is less think about national services that we then test in an area and scale, but more about looking at local initiatives that we can then put scaffolding around to help grow into areas where it makes sense for it to grow and be mediated. And then which I think is important actually, because I just saw, Esther, your really good comment in the chat around how we're embedding cultural beliefs and practices in digital development, because it's something that we're always, there's the sort of core thing we do around making sure everything we do is accessible and trying to provide bilingual services and all of those things, which is still quite transactional, to then the more deeper question that you've got there. And I think that's where we really have to do a lot of partnership with local services to make sure that what we're doing resonates, and so that we've got to get that balance. We've got to improve the flow nationally, but not dictate the route, I think is probably the tagline, of getting it to work nicely together. And there is something I want to touch on, but I might pause because otherwise I'll just try and do too many things, which is around patient-reported outcomes. I think there's something where digital can really help highlight what's working.
Yeah, thanks, Rachel. There's a few questions in the chat, and I think you just started to answer one of them there. So I'll just read out the questions that we've got. So this question: can we meaningfully measure the impact of a digital tool's success in prevention in an individual, or do we have to rely on patterns of health in the population? And it just says in brackets, putting vaccines and infectious disease aside. If anybody'd like to speak to that.
Just trying to find the question in the chat. Can we meaningfully measure the impact? I mean, I think we can, but it comes down to retrospective analysis, and then certainly with kind of the way that these AI regression models work, you can do forecasted benefit based on intervention and the research associated with it, and then the long-term impact on the system. And I suppose that I mean, and Andy has raised like previously, like how do we, if we are going to do these interventions, how do you measure value for money and outcome over a long period of time? And a lot of it is going to be about forecasting and retrospective analysis of the cost of disease on populations based on our existing methods of delivering care, which will change anyway. But I think the kind of the prevention economics are always going to be slightly challenging, because I think we will get to a stage where we will prevent some diseases, but I'm sure there'll be others that may manifest themselves over time, such as COVID, that we'll have to then readjust for. But Andrew's got his hand up.
Thanks, Gary. I guess I just want to kind of add a bit from an experience in seeing this translation. So you've got the public health kind of view, haven't you, of this is the strategic area that we're going to change overall this amount of many people across a population and bring benefit. And then you've got the individual view. I think where I really see the impact delivering is make it tangible to frontline staff. If there's a prevention effort and it's from a kind of a region or a cluster, it's a process, a tool. If it is I can highlight individual risks and monitor them, effectively you could have take a concept from software development, you can have A/B testing. So you could go, right, we're going to do this intervention with this neighborhood, this intervention with this neighborhood, and we'll evaluate the outcomes in terms of patient quality of life, in terms of service usage, and then do a full assessment of that. And I think that's how you really, I guess it's monitored at an individual level, and then you scale it up to get that public health view. Rather than at the moment, I feel sometimes we do a public health view and then try and scale it down, which lends us to wacky ideas like we're going to go to around the bars and do blood pressures and this kind of stuff, which does work, but is it really targeted, or are we just thinking of ingenious ideas to create news kind of cycles? But yeah.
I mean, just following on from that, I mean, one of the projects I have had the fortune of being involved with over my career is the whole systems integrated care program in northwest London, and then trying to scale that platform across London. And they've done some really interesting work on diabetes interventions where they've got clear kind of outcome-based measures. You're talking £70,000 per patient through diabetic interventions and cultural interventions, which they have created kind of demonstrable if you like, dashboards and tools that actually show, over a long-term period that the interventions do work and they do improve the health economics of their local population. And that will be, I think that will be the measure of any intervention we have now, will be, as we've already alluded to on this call, are you improving the outcome for the individuals based on the intervention? Because one of the challenges we do have with any prevention program or any intervention-based program is if you, and this happens in cancer quite a lot. So you end up, you'll treat a cancer, but are you actually improving the person's quality of life after the cancer intervention has taken place? So you do a major surgery, you change somebody's, or you keep a person alive, which is but is their health and well-being, the quality adjusted life year of that individual post intervention, is it going to continue to support the economy, or, and this is how economics works, is it going to become an economic burden? And that's the balance that we talk about when it comes to prevention and economics, is can you support a healthy economy whilst also, and healthy individuals in an economy, versus treating them and keeping them in the system, so to speak. But I'll hand back over to colleagues. So I think the answer to the question is yes, you can measure, but it has to be very targeted and very specific depending on the area of health you're looking at.
I think it might just sharing some of the experience of what we've been doing. So your question is very specifically about the impact of digital tools in the success in prevention, which I'll talk about. But when we're launching digital tools, we almost have 3 parts to what we forecast and then evaluate against. And one is less around the success in prevention, but the immediate, is this going to improve? Is this going to have cash releasing benefits? Is this going to have productivity benefits? So doing the thing that we're already doing, but in a more efficient way. And a good, that could be from introducing digital communications, which might save some costs, through to actually, for example, like in bowel screening, the introduction of the Fit at Home test, the exciting poo test. I pick all the sexy ones. The introduction of that before colonoscopies is a more efficient way of being able to detect some diseases. So there's lots of those measures we have. And then there are the measures that we have, which are sort of in the middle, which are like, are we avoiding hospital admissions and things like that? And then there's the final one, which is like, what are the health outcomes that we're driving here? And there's quite a lot of, we borrow a lot from our peers in public health around how they measure their health outcomes. But what we try to do, very much like Gary and Andy talked about, is isolate when we've introduced an intervention and what that looks like. So have we driven uptake, for example, and therefore this is the improved intervention that we'd expect. If we've improved uptake by 2 or 3% nationally, we see quite a big flow through then in terms of prevention. And we can do that, like Andy said, A/B testing, but also, baselining and trying to be clear that we've got a very particular intervention at a very particular time, and extrapolating from that.
And thanks, Rachel. And I've got another question in the comments here. So given the 10-year life expectancy gap between places like Richmond and Blackpool, which Gary obviously mentioned earlier, how do we ensure that big national projects like the single patient record don't lose the local denominators, the specific community data needed to actually fund prevention for things like mental health and respiratory, can't say it, issues?
That is so I think it's an interesting kind of debate that's ongoing at the moment, I would say, around the multitude of data programs that exist nationally versus locally. I mean, Rachel's already alluded to the fact that we do have to have, even if we've got national data sets, we have to provide some sort of tooling or if you like, empowerment locally to use that data and unlock the power within the data for local programs and support. I think there is huge value personally in having a national single patient record for a number of reasons. There is some of you may know that the Southwest population increases by several million at times over the summer. with the influx of of travel, even within our own country. So having a record that moves with you is quite important, and we kind of are slightly behind the times in comparison to other nations when it comes to having a national record of sorts. But then using that data and empowering patients with tools through the NHS app to enrich that data, I think will be powerful. But then unleashing that information to teams within local communities to then do analytics, I think is possibly the best way forwards. Because there's this whole software engineering concept of divide and conquer. Whereas if you split a problem up into multiple smaller problems, you can solve more problems. So that would be the scientific approach to using the data, I would suggest, but you still need some sort of nationalism. But I'll hand over to Rachel maybe, because probably a bit closer to the thinking than I am.
Yeah, I mean, that was exactly how I frame it personally. And like, I'm not directly leading the single patient record, but I see it as it evolves, being a really good asset that I, nationally, and peers who I work with in prevention across the system can utilize. But it's just one part of the jigsaw puzzle. Like, we're talking about a single patient. It's really kind of key in the patient record. But actually, what's quite interesting in this space is everything. I mean, your question brought it out beautifully. Everything that matters to that person. So the community data about that person and data about the community is really important when we think about prevention. And I fall into the trap, and I have done actually in this conversation, of talking about behavior change and sort of placing all the onus of action on the individual. But, if someone is operating in a food desert and telling them to eat more healthfully is a bit pointless. There's going to have to be community action for some of these things why, I mean, this gets into the wider determinants of health, doesn't it? But wider action around housing and other areas for some of the things we're talking about. But I think the ability of being able to access more easily information about people's health, and for them to access it more easily, can then help as we dovetail it with things. But I would personally be very sad if we got to a place where we lost all the rich data that you're talking about that drives all those local services. That shouldn't be the ambition, in my view, personally.
Okay, we've got a couple of other questions in the chat which are kind of on the same topic. One is, how is digital, e.g. the NHS app, including these beliefs? This was about the question you addressed earlier, Rachel, around cultural beliefs and practices, but it's saying to enable digital literacy in the whole population. And the second kind of related question is, what about the elderly who aren't tech savvy? So really talking about digital inclusion here. So I don't know if anybody would like to speak to that.
Unpopular opinion, possibly. I mean, I think there's about 13% of the adult population or something don't have a smartphone, and one of the challenges the government has is to make sure that 13% of the adult population do have a smartphone, and that we bridge the gap between the digital literacy divide. I think there are always going to be like neurodiversity challenges that we have to factor into, and other kind of disability type challenges we have to factor into our health service through more traditional means. But I think those that can and are able to should be enabled to. So that's the kind of the main point. And I know there has to be a choice in all of this stuff, and we all have a choice whether we want to be involved or not. But I think in order for us to move forward and maintain healthier, more productive and active lives, technology is so fundamental to everything we do now, and not having access to technology is one of the issues, and not having education programs which provide our citizens with the right level of education to use that technology is another challenge that the government needs to resolve through social schemes, etc. But I suppose like the kind of real view that I personally have is like we probably need to make sure those that can do, and we need to support them in doing that, because I think it is the future. And I have taught my own grandmother to use a smartphone, and she's doing wonderfully well with it. and she orders her repeat prescriptions using the NHS app. Rachel, well done. And I think, you know, that is the kind of where we've got to. But as a side, you know, there will always be telephones, traditional telephones, and, you know, traditional methods of access. I just think the outcomes will the outcomes probably won't be as you know, as palatable maybe for those people that aren't digitally able or enabled, which we probably need to keep our eyes on.
Got 10 minutes left. So what I thought I'd do, we had lots of questions and things we wanted to talk about that we haven't got round to. So I thought if I just go to each of you and just give everybody a chance to give some kind of closing thoughts and mention anything which you maybe feel you didn't get a chance to mention. Shall I start with you, Andy?
Thanks, Tammy. Yeah, so I think it's really positive that there's this emphasis on prevention, and that I think digital and AI tools are a great enabler for changing the way we've always gone about this. I think prevention's probably been in every 10-year plan I've ever seen in my lifetime. So it's nice to actually have some more tools to kind of try and genuinely enable that and deliver real impact. For me, what I would like to see more of and the focus on is there are lots of talented people that are working, you know, nurses, social care workers, GPs, that see the problems and know the answers to the problems, and they are looking for the technology to just support them in getting there, whether that's an ABT to make their lives mental load a little bit less, or whether that is I need a new digital tool or a whole platform or the single patient record in the future, and access to that data to make my decisions and my life easier so I can make best use of the time. I think it is, I'm sure it is for kind of Rachel and team to just decide on the kind of long-term direction of that. And I'm really interested to see something we haven't touched on is genetics and research and the role that will play over the next few years. And I think that's underestimated. But the reality is that as neighbourhoods develops in this concept in the next kind of 2-3 years, there needs to be real-world evaluation of all interventions and preventions and early diagnosis, and we're looking to try and enable that locally in Dorset and with our DICE team and our TPH platform. I guess we're looking to create that space where that's whatever the intervention, we can evaluate it and then decide whether that's scalable locally and regionally. But yeah, I'm really excited for the future, and yeah, thank you to both of you for your views so far.
I'll go next because I think Rachel should go last. Rachel's does this every day. But I mean, I've already alluded to, you know, my views are I'm incredibly excited about genomics and, you know, the spread of AI across the kind of prevention, you know, environment. You know, and I think having you know, improving the kind of sequencing and the ability for AI and the models that will come over the next decade to tell me what to do better in order to improve my quality of life as I age, I think is a powerful tool. I still feel like there's a lot of work to be done on the basics though in England, and we have mentioned vaccination screening and all those types of things, but we are still slightly behind the times in some of our kind of vaccination programs, and we do need to continue the drive on those kind of issues. But equally, the NHS app has huge potential, and I think, you know, expanding the app with partners and other services and providing access to day-to-day technology, and you know, I always talk about these care traffic control systems, but I think eventually we should get to a stage where, you know, the data points about us as individuals are flowing into a trusted health platform, which can then give us alerts, warnings, you know, improvement objectives, all those good things that will keep us, you know, out of the red zone, so to speak, when it comes to our health moving forward. So that's my kind of last penny's worth, and I do think the future is very optimistic when it comes to using technology to prevent and support the management of disease in England.
I think you two summed it up beautifully. I was thinking while you were talking, so what we've talked about a lot of ambition here, and I hope it's ambition that everyone on the call shares, because I think we can only do everything we're talking about together. There are so many layers from, and Andy, you're completely right, we didn't even get into really the nature of what we need to do around research and fast evaluation. But what fundamentally needs to be true to make digital tools really help that shift to prevention, and that sort of service loop concept I talked about near the start is making sure we're not designing around single user journeys. We are not a single user journey. We are not a bit of technology that we buy off the shelf and plug in and everything works. We are so much more than that, and it's the set of experiences that we really need to design and work on together. And I think what's cutting through everything that we need to do at its core, it's about enabling and empowering people who are working, which I imagine many of you on this call are doing, are working on digital aspects that improve prevention. It's enabling people like you to look across a range of people's interactions and ensure they remain coherent and aligned and we don't lose them, and that they work for the different people in the unpredictable reality of their very, very messy lives. And I think in a world where we've got a lot of new things coming on stream, we are going to have to make sure that we don't slip into that world where it's just something we buy off the shelf or something that we think is definitely certain, but we enable an experimental, or as the Cabinet Office is saying at the moment, that test, learn and grow mentality to feed through. And that means, and we've talked a lot about the what, but a real focus on the how in the NHS, and garnering brilliant people who are thinking about how do I get this done, and trying to, quite frankly, clear the path. So nationally, I think a lot about how am I enabling way better people than me who sit locally and with real people to do a better job. And I would be really sad if we don't get to a place where we're really thinking and questioning our how, because I don't think we can use the last 10 years of experience to necessarily in the how in digital land deliver the next 10 years. We're going to have to be a little bit more deferential and a little bit more inquisitive, and I think there is probably a key role in amongst some great working with some great innovators to also have some really core NHS services which are built for the NHS and really work for their needs. So hopefully a call for everyone to come together, and I'm quite excited for the years ahead as we start really motoring around some of these topics. Not least in national land, spending review means a 3-year spending settlement, which we haven't had for so long, which is brilliant.
Rachel, and yeah, a big thanks to all of our panel for taking the time to join us today. Thanks also to the audience. I hope you found it to be a really interesting discussion. This is recorded and it will be going up onto the Digital Health website, so you can revisit it or you can share it with colleagues. Yeah, so a big thank you to everybody. Have a good weekend and see you again soon.
Thank you, Tammy. Thank